Hi, good morning, and welcome to Grand Rounds on this brisk, rainy winter day. We're thrilled to have Shanna Patterson with us today. She's a great friend to the Department of Medicine and really just delighted to welcome her and are looking forward to her talk on neuropathy. Shanna is the site medical director for the Department of Neurology for Mount Sinai Morningside and Mount Sinai West. She's also the director of electromyography, and she's an assistant professor in the Department of Neurology at Icahn School of Medicine at Mount Sinai. She received her Bachelor of Science and her MD degrees from the University of Southern California, and then completed her internship, her preliminary year at St. Vincent's Hospital Medical Center downtown, and then her residency in neurology, as well as a fellowship in neurophysiology at Columbia University Medical Center. She's really had a wonderful career to date, and she's focused first on neuropathy, and neuropathy, of course, is super important to all of us, but perhaps most important for people practicing general internal medicine and fields like diabetology and rheumatology. Also has done a lot of work in quality, and in particular, its quality relates to how we talk to our patients and how we talk to ourselves and each other about our patients. Is an epic champion. I didn't know that, Shanna, and so I'm going to be calling you. And then also has done a lot of important work around wellness, both at the level of general medical education and how we think about our trainees and also our younger faculty, and creating spaces, safe spaces for them to talk about their experience of being physicians in the environment in which you work. Shanna, if you didn't realize, was a 2018 recipient of the Society of St. Luke's Roosevelt's Distinguished Young Physician Award. She also won the Halliday Award for Patient Education. And as I mentioned, Shanna, I think John would echo this, is really such a great friend to us and a great supporter of the Department of Medicine. It's wonderful to have you here. Welcome.
Thank you so much for that kind introduction. It's really an honor to be here and to spend time with all of you this morning. And so without further ado, let's get started. I want to say that this is a little anxiety producing because over the years, usually I have been asked to speak to groups of surgeons, and I feel much more kind of comfortable with medical knowledge because you always feel like you probably know a lot more than they do and so forth. So this is an intimidating audience right from the beginning before I even get started. But I want to, that's right. So what I want to say is that I sincerely hope that I can give you my objectives here really to help impart some information I hope will be helpful to all of you in the work that you do, and also to take a little bit of a holistic look at patient care with respect to neuropathy, not just in terms of the medical aspects per se, but also certain patient interaction aspects and other things that we do or patients may ask us about in terms of helping them with their condition. So again, to go over an overview, I think, the first part of the talk, I'd like to focus on things in terms of just a general classification and evaluation of peripheral neuropathy, as well as certain diagnostic aspects and when to refer to a neurologist. We're always happy to see patients, but there's certain criteria cases that certainly you wouldn't want to miss an opportunity to engage with a partner in neurology. And then also just some brief discussion about treatment. But what I'd like to then focus on in the latter part of the talk is really thinking about the case from the patient's perspective, where I think that, some cases of neuropathy are treatable, some cases it's really about symptomatic management, and some cases are so-called idiopathic. And how do we really kind of not give the patient a sense of that they're on their own? How do we partner with them, let them know that we're their partners? And there's actually a lot of things that we can do to even help improve their quality of life with this chronic condition. So just to really start with broad definitions and epidemiology, neuropathy is one of the most prevalent neurological conditions encountered by physicians of all specialties. And in terms of the prevalence, this is indeed a condition that tends to increase with age due to a variety of factors. And according to some recent reviews, the prevalence is about 8% over the age of 55. So in general, depending on how many patients you're seeing on a daily basis, you're probably seeing at least a patient a day that has neuropathy. And just to back up a little bit in terms of the types of nerves that we're talking about. So when we talk about peripheral neuropathy, we're of course talking about a pathology that involves nerves outside of the brain and the spinal cord by definition. And a lot of these are what we call large diameter nerve fibers. This is a schematic of anatomy of a microscopic anatomy with a cross-sectional perspective of a large diameter nerve fiber. And you can see this is kind of like a bundled structure at the microscopic level. Actually, muscle anatomy is rather similar to this, where you have sort of the individual axons are like these little, let me see here, are these little dots. And then they are actually bundled together in groups called fascicles. And then there's a variety of concentric layers of connective tissue. There's blood vessels that supply blood flow, of course, to the nerves at a microscopic level. Some of these nerves have myelin, and this is where the myelin is coating individual axons. Here is a depiction of this. So peripheral nerves, depending on what kinds of axons are bundled together inside of this nerve, can be either exclusively motor, exclusively sensory, or a mixture of both functions in the same nerve. And these are the nerves that you'll see, like if we're dissecting a cadaver and you're seeing like these kind of strings-like structures. Those are the large diameter nerves. Some of them are myelinated, some are unmyelinated, and this is the population of nerves that we can test when we're using EMG technology. And the reason why I mention this is that there are certain types of nerves that we cannot pick up abnormalities with an EMG, and I'll get into that more a little bit later on. I want to mention the autonomic nervous system. We could have a whole lecture just on the autonomic nervous system and autonomic testing. There are whole textbooks dedicated to this, but I want to mention it here briefly because autonomic nerves, in terms of the peripheral projections of the system, are oftentimes potentially involved in peripheral neuropathy. Most of the postganglionic axons from autonomic ganglia are unmyelinated. So these would be slower conducting, unmyelinated nerve projections. Autonomic symptoms are also frequently underreported in neuropathy, or the patient might have what are autonomic symptoms related to their neuropathy, but they might not attribute them, or their providers might not attribute them to the neuropathy potentially. And this might include something like dizziness, or perhaps gastrointestinal symptoms, or symptoms related to like a neurogenic bladder and so forth, or sweating changes. So this is something important to think about. Sometimes there are more rare cases of neuropathy, which are more exclusively autonomic in nature, but much more commonly we see patients with kind of even a diabetic neuropathy who may develop dizziness and other autonomic complications as time goes on. Again, this concept of if there is a large fiber neuropathy, which I mentioned before with the structure that we looked at a couple slides ago, there is actually a small fiber neuropathy, isolated small fiber neuropathy. This is a sensory-only neuropathy. These small unmyelinated nerve fibers course throughout our skin, and these nerve fibers observe sensation exclusively. So if the patient has any component of weakness, it cannot be an isolated small. These nerve fibers are involved in pain transmission. Patients may have sensory loss. Again, they may also have some dysautonomia. And if a patient has an isolated small fiber neuropathy with sensory symptoms, it is not detectable on EMG testing because EMGs only detect large nerve fiber pathology. To me, this is really interesting because, as I'm going to get into in a few moments, now we have an increased ability to easily test for small fiber sensory neuropathy. But in the past, this was not as readily available. And so I can imagine that there must have been a number of patients with true sensory neuropathy symptoms who really didn't have a diagnosis. And I think that now we're in a fortunate position where we can offer a more comprehensive workup and offer a lot of these patients diagnoses. So we talk about the neurological comprehensive examination all the time. And when when we're working in our practices where we're educating students or residents, we're focusing on the comprehensive neurological exam or maybe the focused neurological exam. But let's say you're a busy primary care provider and you have a patient, you want to know that you're screening adequately for peripheral neuropathy based on the physical examination, and you have 1 or 2 minutes to do this. So there actually have been studies which have looked at what is the most sensitive and efficient combination of physical examination maneuvers that you can do in this context to really adequately look for possible peripheral neuropathy. And so the combination of examination is, first of all, I want to say that studies have shown that history alone is insufficient. Some patients will report to you that they have symptoms of neuropathy, whether it's tingling or numbness or so forth. But some patients don't have those symptoms. They have what we call kind of negative neurological symptoms. Maybe they have numbness, but maybe they don't notice that they have numbness. Maybe they have what we call sensory ataxia, which means they're a little off balance, but it's because they can't feel their feet. But they just report to you that they're off balance. And as we know, that can mean so many different things. So in essence, it can be very helpful to look for objective signs on exam of neuropathy so that you can ensure that you're not missing this. So this is really the core of physical examination that's been shown to be effective in screening for neuropathy. A combination of light touch examination, specifically using a 10-gram monofilament, if you can get them. I will actually say that I don't have them or carry them around with me, but I usually use light touch sensation with either like a swab that I use and I actually snap it in half so you can make one side sharp and another side kind of soft and adequate for light touch testing. However, to be clear, like it's not perfect, and this is really the gold standard if you wanted to really kind of have a very, a tool that is reliably going to test a very light touch sensation, regardless of how hard you push on it. These things bend if you've never seen them, so it's really a nice way to have a consistent examination in terms of how you're testing light touch sensation. Also, vibratory sensation using the 128 hertz weighted tuning fork, which is an image of that is there as well. This is the tuning fork. It is not the same tuning fork that we used for hearing and all these sort of things. This really gives you a good vibratory sensation assessment. If you're really into this, there is something that's actually quantitative where you can quantitatively test vibration called a Rydell Cipher tuning fork. And it looks like this, except at the ends, there's these little numerical weights that when they vibrate, there are triangles on them, and the triangles, as the vibration is resolving, the triangles kind of turn from a blurry image to a solid arrow, and there are numbers on the side. So for some patients, if you're really into quantitative vibratory testing at the bedside, you can actually do that by just looking at when the patient says, okay, I can't feel that anymore, where is the number? And then there are different publications that map this out. But at minimum, this is really the basic tool for vibration sensation. And ankle deep tendon reflexes. Again, this exam is really focused on the feet because the vast majority of neuropathies, lumping them all together, are length dependent. And so a foot examination is what is going to be the highest yield when you're looking at population as a whole. Not all neuropathies present this way, but if you're really seeing a lot of patients and you want to have kind of the most efficient physical exam approach, we're focusing on the feet, including ankle deep tendon reflexes, specifically looking for hyporeflexia or areflexia. Now, before we get into blood tests or anything else along those lines, if you're just finishing your clinical evaluation of a patient who you suspect has neuropathy in any setting, you can actually drive for additional workup and thought process about the condition just by a clinical classification alone. And these are really the elements of the clinical classification. So the chronicity, is this acute or chronic? Oftentimes, if it's chronic, we may or may not know that it's chronic sometimes, especially if the patient hasn't noticed their symptoms. If it's an acute setting, these may be patients that we're seeing in the emergency room with Guillain-Barré or a variant thereof. But that's an important element of the classification. Clinical symptom distribution. Again, the most common pattern that we see is what we call length-dependent neuropathy, which means that the longest nerves are affected first, and the longest peripheral nerves are in the feet. I almost like to think about it, take, for example, diabetes as an insult to the nerves. I almost like to think about it as a train track. And if you're bombing a train track, just kind of in terms of statistically, probably if you have a very long piece of train track and there's random sort of bombs dropping from the air, the longest train track might have the highest chance of taking most hits as opposed to shorter ones. So that's, in a way, mentally, as you can kind of imagine, with the vast majority of toxic neuropathies or diabetic neuropathy being one of them, that's why we tend to see the symptoms first in the longest peripheral nerves and the manifestations first in the feet. And then progressively, as time goes on, the symptoms can progress above the feet to the ankles, the lower shins. If it's really progressing up to the knees, then involving like the fingertips and the hands and so forth. But there are other distributions as well. There's certain neuropathies which are multifocal, certain neuropathies which can have more, unusual, but certain neuropathies which can have proximal involvement more so than distal involvement. Clinical modality is affected. So is this a motor neuropathy, which means associated with weakness? Is this a sensory neuropathy? Are there autonomic features? Most commonly, we see a combination. So we might see, for example, a patient who has a lot of sensory symptoms, but maybe there's a little atrophy of intrinsic foot muscles, maybe weakness that may or may not have a clinical significance depending on what the patient's level of activity is. But again, but there are certain isolated motor neuropathies, and there are isolated sensory neuropathies. There are rare autonomic isolated neuropathies. And the most common, of course, is a length-dependent, sensory-predominant peripheral neuropathy. And these tend to be patients who have tingling, burning, numbness in the feet, and that may progress over time to involve some weakness in their feet, which they may or may not notice clinically. But this is really a classification that helps drive your workup and your decision in terms of how to manage the patient and even how to support them going forward. So I wanted to take a few minutes now to speak about different types of tests, objective tests to diagnose neuropathy. So we see many patients who have a clinical diagnosis for neuropathy, but it's never been objectively confirmed with testing. I think depending on your practice, depending on the patient's symptoms, it may or may not be essential to objectively confirm the diagnosis, but as a neurologist, this is something that we are involved in doing quite frequently. And the test that most people are familiar with is called EMG and nerve conduction study testing. Again, to just reemphasize, this is a test that only is really picking up pathology with those large diameter nerve fibers. And so what does that allow us to do? That allows us to localize the neuropathy. It allows us to tell what the severity is. I'm not speaking here about muscle or neuromuscular junction pathology, but these are also structures that we can assess with EMG nerve conduction technology. Speaking about what information can we get using an EMG with respect to the peripheral nerves. So we can actually confirm that there is a peripheral nerve involvement. Sometimes patients have strange symptoms and they're actually referable to the spinal cord, for example. And so there can be masquerades of neuropathy that actually are not related to peripheral nerves. But this test allows us to confirm that that's the case. We can tell if the neuropathy is primarily involving pathology from the axons or if there is a demyelinating component to the neuropathy. That is actually really important. The vast majority of neuropathies are axonal. The minority are demyelinating, but those demyelinating neuropathies are likely to potentially be autoimmune in nature. And so we treat them in a completely different way with agents such as IVIG, which I'll get into more in a minute. But it's very important to identify those demyelinating neuropathies because it really takes you in a whole different treatment approach for those patients and workup approach as well. We can identify on an EMG what fiber types are involved. Is this a predominantly sensory neuropathy? Is there motor involvement, or do we see evidence of both motor and sensory pathology? We can actually tell to a certain extent what the temporal course is. Mostly this happens if we see muscle denervation associated with the neuropathy. So we can use the EMG portion to look for any signs of denervation. We can look for signs of active or chronic denervation. And so for some patients, if they say, I've only noticed these symptoms over the last week or 2 weeks, and then we do the EMG and we pick up signs of long-standing distal chronic neuropathic changes on the EMG, we might say, maybe they've just noticed the symptoms over the last couple of weeks for whatever reason, which we see a lot. But we can sometimes say, this looks like a process that's been going on for some time, and maybe for whatever reason, the patient just hasn't noticed it before. And that can be helpful to be able to objectively map out. EMGs can give us, for most patients, they have a single EMG. For some patients, for example, patients who maybe have one of these demyelinating neuropathies and we're treating them with different immunologic agents, it serves as a baseline, an objective baseline that you can use to repeat over time, not frequently, but maybe at minimum over a course of months or years, to compare and see, is the neuropathy getting better or getting worse and so forth. That's important for some patients because it helps guide their treatment. Certainly patients oftentimes are excellent reporters of what they feel, but sometimes it can be really tricky, and especially with sensory symptoms of neuropathy, it can be hard for patients to tell sometimes, is this getting better or is this worse? Sometimes increased tingling or paresthesias might not mean that the neuropathy is worsening. It might mean, especially if it's not, if it's spreading over new areas of the body, that's one thing. But if it's the same region that's involved and maybe it's more tingling one day and less tingling the next day, it may mean that there's some nerve regeneration. It might not mean that there's actually worsening of the neuropathy itself. And so this can be helpful because literally we get numbers in terms of amplitudes and conduction velocities that we can, especially looking, of course, at the same nerves, compare one study to the next to really look for objective signs of worsening or improvement, or to reassure the patient that no, in fact, don't worry, the condition is not worsening, even though they might have a concern that it is. Nerve biopsy, in terms of this, this is a surgical procedure which is done in the operating room. Nerve biopsy sometimes is done in conjunction with a muscle biopsy when necessary, but nerve biopsies are sometimes done to really assess for certain types of neuropathy. We do not do nerve biopsies very commonly. I think especially now that we have so many more resources, including different blood tests and other things that we can do to help characterize neuropathies further. It is not very common that we're ordering nerve biopsies on patients. Maybe, once a year or something like that, I think, in terms of my practice, but it is something that perhaps was used more historically, and it certainly is widely available. So neuropathies, that I think people used to think of this more using for some of these demyelinating neuropathies, such as CIDP or chronic inflammatory demyelinating polyneuropathy. I put the question mark there because this really isn't a case where we tend to use nerve biopsies nearly as much as I think as we did in the past. But certain neuropathies where we suspect a vasculitis, it's very important. You can see inflammation, inflammatory cells infiltrating the nerve, and that can be helpful in confirming these cases. Sarcoid, certain infectious types of neuropathy, such as leprosy or infiltrative neuropathies. This is an image showing amyloid deposits on a nerve biopsy. So these are some examples of cases where we might want, if we suspect this, we might want to have a nerve biopsy to help confirm this diagnosis. But the vast majority of patients will not need a nerve biopsy, which itself does carry some long-term, minor, but long-term morbidity. Because you are removing a piece of the nerve, they will have some area of numbness where the biopsy took place. So which if it's really important, that's fine, but it's not something that we do lightly. So pivoting a little bit to small fiber neuropathy testing. So as I mentioned, there are different types of small diameter nerve fibers, unmyelinated nerve fibers. There's a population that's in our skin, and then there's the autonomic nerve fibers, which are themselves unmyelinated small diameter nerve fibers. For autonomic testing, there's a whole variety of different modalities. Some of them are very involved and not very commonly found. This is an image of one essentially where they're doing a sweat testing to look for normal or abnormal distribution of sweating on a patient. They literally cover these patients in powder and then heat them up. And then depending on where they're sweating, the powder turns these colors. So it's messy, it's involved. You have a naked patient covered in powder and you're warming them up in some environment till they're sweating. So you can imagine that it's really cool, and there's a lot of different diagrams, that are based on this that, help really illustrate dramatically kind of what the nature of these conditions is, and how mapping out distal versus global or multifocal involvement, because the sweat glands themselves are, of course, innervated by these small diameter nerve fibers. But in practice, this is not something that's very commonly done, and we have other ways of testing for small fiber neuropathy. Now, to be clear, you're not going to be doing autonomic testing unless the patient really has autonomic symptoms. There is a provider named Jessica Robinson Papp. She's based at Mount Sinai Hospital. She offers she's in the Department of Neurology and offers autonomic testing. From a cardiology perspective, like tilt table testing will pick up some features, but there are certain elements of the neurological kind of version of that, looking at autonomic features like beat-to-beat variability and heart rate with different positions and other maneuvers that are a little more involved, and they'll comment, depending on the provider, on autonomic versus sympathetic or parasympathetic function as manifested even through different heart rate patterns and so forth during the test. So it's not to say we can often get a lot of information potentially from a routine kind of tilt table test, but depending on the patient, there can be value, and there are additional maneuvers offered in the neurology kind of autonomic testing realm. But if we were to look at the sensory nerve fibers in the skin, we can actually do a very simple punch biopsy of the skin and get a picture of whether or not the patient has this isolated sensory small fiber neuropathy. This is a picture of a pathological staining. These little black squiggly lines are actually stained small diameter nerve fibers in the epidermis. There is actually a company called Therapath. They have a nice website with a lot of different examples of different things, sort of provider resources. One of their directors used to be the head of neuropathology at Columbia, and he's one of their senior pathologists as part of this company, which ironically is just a few blocks away from us in Midtown. So it's kind of a nice resource. And we don't have somebody who does this skin pathology analysis all the time, so it's nice to be able to have them as partners. But the idea is that this is a very simple office-based procedure. This is a punch biopsy that you can do as part of an office visit. They don't have to have stitches. There's minimal bleeding. They wear a bandage afterward, and you can get the pathological analysis back. I don't have a picture here, but actually they also do sweat gland analysis because there's sweat glands in our skin, so they can see the sort of glomerular appearance of like these nerve fibers that are innervating the sweat glands, and they look at the density of the nerve fibers. So in a small fiber neuropathy, sensory small fiber neuropathy, you see a reduced epidermal nerve fiber density, and they have normals for different parts of the body. So you cannot biopsy any part of the body. If the patient said, oh, I have it right here only, can you biopsy right there? The answer is no, because they've looked at what are the normal values for certain specific locations. There's one on the forearm, there's one over the foot, one just above the ankle a little bit, and a side over the thigh. So you have to use their standardized site so that they're comparing normal values. But that being said, usually we can find a situation where we can, usually the patient has one of those areas or close to one of those areas that's involved. And then this is a very easy way to help confirm for those patients who have sensory, especially sensory symptoms, and the EMG is negative. So they do have certain criteria that we go through. We usually start with an EMG, even if we have a low clinical suspicion that it may show something, because A, it's not an invasive test, and B, for insurance purposes, insurance companies to cover the pathology analysis want to know that the patient A, has no signs of other large fiber neuropathy clinically, like weakness, and B, that they've had an EMG test ideally, which is negative, so they don't have a large fiber neuropathy component. What's interesting is that, here it says that the sensitivity is 90% in diagnosing a small fiber neuropathy, and the specificity is also high. What's interesting is they said, the same study showed that clinically, based on history, alone, that the sensitivity clinically was about 50%. So it's interesting, and, I think that it's something to kind of bear in mind for those patients with strange sensory symptoms where the other workup is negative. And again, in my mind, this is really powerful because this is an easy tool that is more broadly available. A lot of clinicians now who are going through kind of neuromuscular focused or EMG fellowships are learning how to do skin biopsies for their patients. And so patients where in decades past had a normal EMG and were told, well, we don't know what's wrong with you, everything's negative. Now we have this additional tool to help diagnose these patients. So once you have a diagnosis of neuropathy, then next we asked ourselves, well, what's causing the neuropathy? Because ideally, in order to treat the neuropathy, we need to find out the cause, and that informs how we can potentially halt the progression or even reverse the condition. Length-dependent peripheral neuropathy, in terms of a workup, which we'll kind of go through different elements of a workup, the cause is identified in about 74 to 82% of cases. So on the one hand, it's discouraging because then you have up to a quarter of patients for which you have no cause, and those are patients with the so-called idiopathic neuropathy. Depending on certain studies, whichever ones you're looking at, the percentage of Idiopathic neuropathy cases for isolated sensory small fiber neuropathy can be higher than this, 30 or 35% of cases, according to certain papers you can read. But the good news is, in some ways, is that patients who we've been following for a while, and we can say, okay, there's idiopathic neuropathy, but this falls into this category of length-dependent, foot symptoms and so forth. When they look at some of these patients over time, these patients also tend to have very, very slow or minimal progression over time. So when patients ask me if you can't find the cause of my condition, I have numbness or burning over my feet, maybe a little bit of imbalance. We diagnosed neuropathy. We haven't been able to find the cause. I've had this for several years. Am I going to end up in a wheelchair someday? I've been Googling neuropathy. I can say to them, it's nice to be able to say, and it's true that, based on what we know, in general, the past for these patients tends to predict the future. And you can say, I wish that we had more information, but I can reassure you that based on what we know, chances are that is not going to happen. This is not going to likely to suddenly start spiraling out of control once we know that they've had these similar symptoms for a number of years and we can identify them as part of this group of patients. What does that mean in terms of what kind of neuropathies are these? We'll get more into that. And I think that according, again, to some schools of thought, hereditary neuropathy may be the most commonly overlooked cause. It may also be one of the areas where we have, for some patients, they don't pursue genetic testing if they feel like, well, my symptoms are relatively stable. I'm not sure if anyone else in my family has these symptoms, especially if they're mild. Nobody in the family may have talked about them. And genetic testing can be expensive. It can be hard to get. And honestly, it can also, I think we're in a position where we're constantly learning about new genetic influences of peripheral neuropathy over time. And it may be that we don't know the full complement of those at this time for patients who even do have genetic testing. History may yield diagnosis in some patients. So for example, there's certain types of toxic medication-related neuropathies. Obviously, chemotherapy patients, they always know that they've had chemotherapy. That's never really like an obscure part of their history that we have to mull over for very long. That can be a cause of chronic neuropathy, which tends to remain stable over time, potentially even years after we've given and stopped giving chemotherapy. Statins, there's been a mixed picture in terms of like certain statins are more likely to cause neuropathy than others. And some patients obviously take these medications for years and never have any problems with them whatsoever. So it's a little bit of a gray zone, but in terms of history, there's things that you can go through with patients and ask them if you've taken certain medications. And it may not be something that you will find in a blood test, but something really that you find in a detailed targeted history that helps kind of give you an idea of what might be the cause for the patient's condition. So if you're going to be doing blood tests or starting to do blood tests, like what are you going to send that will have the highest yield in most patients of giving you the cause of neuropathy? This is a table which is a sort of starting basic evaluation for this chronic length-dependent peripheral neuropathy, which again, in terms of clinical classification, is the most common type of neuropathy that we see. And the blue arrows I've highlighted sort of the highest yield components. And the little A superscripts indicate areas where, again, these are the highest percentage of cases identified. So fasting glucose is good, but hemoglobin A1C is better. There used to be this kind of impaired glucose tolerance or like, borderline diabetes debate about like, can that even cause neuropathy? And going back like to 2011 or 12, there was this school of thought that yes, absolutely. And there were some cool studies where they looked at serial skin epidermal nerve fiber densities and saw that patients with like these, not even diabetes, but borderline diabetes had neuropathy, and then they improved their glycemic control and it got better. And now there's more recent publications that say, no, this isn't the case. It's really just if you have diabetes. So I think this is an ongoing conversation between endocrinology and neurology and learning more about what is it for some patients about this whole metabolic syndrome that leads them down the path of some of these complications. And I think we're still learning about that. But nonetheless, certainly looking to see if a patient has diabetes is important, especially if the patients sometimes we meet may not go to see a primary care doctor very often in some cases. Also, looking for monoclonal protein abnormalities. This is important in terms of screening for that. These can be associated, even like MGUS associated with peripheral neuropathy. This may be like a watch and wait situation even, but in terms of identifying neurological underpinnings for neurological complications. It's important, and I partner sometimes with hematologists where we're just monitoring patients and treating their neuropathy symptoms. There may not be anything else to do, but this can be helpful for some patients in identifying the cause of neuropathy. Vitamin B12 we think of as instructive, and vitamin B12 deficiency can cause a number of neurological complications, including subacute combined degeneration with spinal cord manifestations, but also neuropathy. But interestingly, and this is where the 9% with methylmalonic acid comes into play, for some patients, they have almost like a cellular metabolic sensitivity to even low range B12, which shows up in our lab reports as normal, but on the low side of normal. So maybe like 300, I think our cutoff is like 280 something or something like this. And so for patients who are in the maybe 300 range, for certain patients, this actually is a physiologic deficiency for them, which can result in symptoms. So testing methylmalonic acid can be helpful and increase that yield. For some patients, if they haven't taken B12 or if they're traveling or something, I'll say just try taking B12, see if it helps you feel better, because it's cheap and easy and it's not going to cause toxicity and so forth. Other types of conditions which are less common but are things that we think about when we're evaluating patients further: celiac disease, 2.5% of peripheral neuropathy causes presenting to a tertiary referral center were found to be celiac disease. Obviously, this is a very special subset of patients. This is not your all-comers in the general population. And this happened to be, I think, a tertiary care center that had a big celiac disease treatment GI department at the same time. So that kind of biases things a little bit, but it's still something important to think about. And even the literature in this area bears out that even some patients who don't have gastrointestinal symptoms or maybe haven't noticed them yet can sometimes present with more of a neuropathy or neurological manifestations of the condition. Other types of deficiencies we think about as well. I would say, especially in my personal experience being affiliated with Morningside, where we have a really robust bariatric surgery group, I tend to see patients maybe once or twice a year that have some other vitamin deficiencies causing neuropathy, even if the levels for them are maybe in the low normal range, or they say, well, I've been taking my supplements. Sometimes we find that for whatever reason, it's something that has metabolic in their body to manifest in this way. So that's something that we tend to see more of, at least in our hospital system. These are not patients who are overtly otherwise like malnourished, but we look for it and think about it. Alcohol has toxicity in terms of causing neuropathy, both nutritionally, because sometimes these patients are thiamine deficient, but also there is an independent neurotoxic effect. Really, we're talking about moderate or alcohol, abuse kind of levels of consumption, but a direct neurotoxic effect on nerves as well. And occasionally we'll see patients on the inpatient side, so this might be like a consult service thing that sometimes we see, where patients are sober for the first time in a while, and then they notice their neuropathy symptoms. And so there's this like moment where we're thinking, is this like an acute neuropathy in this patient? But when you tease it apart and do a workup, you find out, no, this is a chronic condition. And then you think, it sometimes seems that the patients may just be noticing their symptoms more for the first time, especially in their kind of like a detox setting. Genetic testing can also be helpful, but if you have a patient, in terms of recommendations and thinking about cost of care and so forth, if you have a patient who you have idiopathic neuropathy, but there's no known family history, we don't really do like a shotgun approach to genetic testing in all patients. If there's not an otherwise reason to suspect a genetic underpinning for their disease. This is a very busy slide on purpose to give you kind of a picture of, one, my headaches as an epic champion and a neurologist trying to send these tests, but two, to give you kind of an idea of the complexity of when we talk about these autoimmune neuropathies with potentially like demyelinating features. There's a lot of different antibodies out there that can be involved in these presentations. Some of them are paraneoplastic, some of them are not paraneoplastic and are just autoimmune. Some of them relate much more specifically to motor demyelinating neuropathies like anti-MAG or GM1. We had a patient at St. Luke's recently who had an acute motor neuropathy, almost like a motor Guillain-Barré variant with one of these antibodies. That was informative in terms of his care and his diagnosis and his treatment, actually. So some of these antibodies really drive your treatment in a specific direction. Depending on the antibody, it might inform you that, oh, plasma exchange is more appropriate than IVIG, or that other, like rituximab, might be an important consideration for some of these cases. So we do this antibody testing, but it is not something that we would think of for like a routine length-dependent axonal peripheral neuropathy. These are more specific cases or combinations of tests that you're ordering for some patients. Some of them are easy to order in Epic, and some of them you cannot order in Epic. And so it is challenging. This is actually from Washington University. They have a robust neuromuscular lab there, and this is a screenshot of their requisition sheet. But just to give you an idea of these panels and how complex, this is kind of another level that we look at, but in a very targeted way for certain patients. And just a quick word about genetic neuropathy. So I don't know how many of you have seen patients with Charcot-Marie-Tooth, but sometimes it can be very dramatic, or you see them and you see their family members and they all have these very characteristic, people used to call them like champagne leg bottles because they have this dramatic like tapering more distally. But at any rate, the point of this slide I want to make is that along the same lines of the observation earlier that genetic underpinnings may be one of the most under-recognized causes, that if you look at these patients, especially like A and B, which is the same patient, you can see like you might not think that this patient looks like they have good muscle bulk. There's nothing like really that abnormal if you were just at casual glance in terms of the appearance here, but this is a patient with Charcot-Marie-Tooth as well. So there is a spectrum, and I think though we think of things as classic presentations, there's really clearly a spectrum in terms of what you may see. Or one of the interesting things here that they're showing on the bottom is that for some of these patients, when they're standing up, in terms of the changes like hammer toes and so forth, they're not as noticeable as when the patient is not bearing weight. And then you can appreciate more fully the atrophy in the foot musculature and the hammer toe appearance and so forth. So I think, especially if you're seeing a patient, quickly, the changes may be subtle or not apparent, or for that matter, if it's a milder phenotype, patients and family members, depending on the severity of the condition, might not even notice or might not talk about the fact that other family members have symptoms because it might be very, very mild presentation. So diabetic neuropathy, how many patients have it? How many patients have it at the beginning of their diagnosis? How many patients have it over time? Again, according to one recent survey, 8% of patients have diabetic neuropathy at the time of diagnosis. And over time, as the disease progresses, depending on if you're using clinical or clinical and EMG to make the diagnosis in patients who might not self-report, then it turns out to be something along the lines of 30 to 66%, which is a huge range difference in neuropathy and diabetes as the condition progresses for longer periods of time. Relationship between does more severe diabetes or less severe diabetes map out with neuropathy? We'd like to think clearly, once you have very, very high hemoglobin, A1C is in 10 or 8 or something, that, usually we do see neuropathy in those patients. But I would say that there really, in my opinion, seems to be a multifactorial case because you'll see patients with very relatively well-controlled diabetes who present with neuropathy, and then many of them don't have it. So I think there's so many different factors that are going on, not just with respect to the peripheral nerves, but there's actually a lot of interesting brain research as well, looking at the effects of diabetes on the brain itself, independent of strokes. So I think there's a lot that we're still learning, but not having diabetes is certainly better than having diabetes, is the message, I think. But this is really information in terms of how often are we seeing peripheral neuropathy in diabetic patients. And when to refer to a neurologist. Neuropathies when specialty consultation would be, for this group, I think clearly, and most of these would trigger alarms. If this is something that's acute, that's rapidly progressive, that there are, severe functional limitations, whether it's from pain or whether it's from weakness, if it's multifocal, anything that's not mapping out to that classic length-dependent presentation or severe dysautonomia, these are reasons where you really want to have a neurologist partner, although we are always happy to partner with you in any case. Treating neuropathy. So especially in cases where people say, oh, it's idiopathic. I have patients who come to me and say, I've seen other doctors and they said, well, I can do nothing for you. And that's just not really something, A, that's true, or two, that's helpful in terms of how we can help our patients. Occasionally we can cure neuropathy, halt the progression, or improve it, but often we can help improve the patient's experience and quality of life. Treating the underlying cause if possible. So of course, if you identify a vitamin deficiency, you replete, the vitamin. Some cases, if it's a patient with HIV, you can't make the HIV necessarily go away, but managing it over time and helping the patient manage their symptoms is important. In terms of some of these demyelinating neuropathies, such as CIDP, we're treating the patient with IVIG, other immunologic agents in some cases, and even now, more recently, there was a study that actually showed benefit of subcutaneous immunoglobulin, which can be much more helpful for patients in terms of ease of administration. They don't have to go to infusion center, and also they can self-administer it, and there's fewer systemic side effects. So again, we're really improving with time quality of life for some of these patients, even with chronic autoimmune peripheral neuropathies. I will say, just as a comment for those of you who follow this field, there is this increasing kind of simultaneously exciting and sometimes baffling autoimmune gray zone that we find ourselves in, and maybe a number of you find yourselves in the same zone, where things that we don't know if they have an autoimmune underpinning are increasingly thought that maybe they do, even if we don't have any objective proof that that's the case, and then people start treating them with these other medications. So actually, Dr. Oaklander is a researcher at Harvard in the area focusing on autoimmune small fiber neuropathy, and she's done some studies looking at should we give IVIG to patients essentially with apparently autoimmune small fiber neuropathy, where there isn't an antibody, but we think based on some history that maybe this is an autoimmune condition. And so we treat patients, she's treating patients with IVIG, and patients will come to me and say, I want IVIG. And this is not a randomized controlled clinical trial. This is a researcher. And it's some of these patients are really passionate. I've seen patients in the hospital here and in the office. All of them are mentioning this. And then when you go in the inflammation autoimmune kind of Google world, then the wheels really fall off, and it becomes kind of challenging to talk to these patients. And not only that, but actually there's other research which is interesting or challenging depending on your perspective, and some of it's pseudo research, really kind of increasingly lumping together maybe these small fiber neuropathy patients that we couldn't previously diagnose. Maybe this is really an overlap with fibromyalgia and chronic fatigue syndrome, which also is now known as myalgic encephalomyelitis, and some patients erythromelalgia. So I'll have some of these patients who come to me with chronic fatigue, which they call myalgic encephalomyelitis, which I didn't realize, who want IVIG because it might be related to small fiber neuropathy and apparently autoimmune small fiber neuropathy. So there is this whole world that we're in. And my hope is that 10 or 20 years from now, we have more clarity, and that this is an exciting kind of frontier of medicine, but it can certainly be challenging, and patients will find a lot of literature on this. Some of it is scientific and some of it's not, and they will bring it to you and ask for very specific treatments. So treating people, I don't know how many of you know Coach Wooden, but I really learned more about Coach Wooden from the System Chair of Neurology, Barbara Vickery, who I recently learned used to be a basketball coach for her children, and used to live in Los Angeles because she was at UCLA, and so that's how I've come to know and appreciate Coach Wooden. But he has some great inspiring quotes, including never let the things you cannot do prevent you from doing the things you can. And there's a lot we can do to help people with neuropathy. So the importance of symptom management, even for patients who maybe have something like thiamine deficiency, and we replete the thiamine and you say, okay, well, things should be better now. And even if they are better on EMG, sometimes patients have chronic lingering neuropathic symptoms that require chronic treatment and can be really bothersome for the patient. Of course, in cases where neuropathy is idiopathic or untreatable, then all we have is symptomatic management. And so it's really important to partner with patients on a long-term basis and work with them on how we manage the symptoms. Not only that, but upwards of half of patients with chronic pain for any cause, but neuropathic pain in particular, have other symptoms or problems in terms of sleep disturbances and insomnia and pain. It's like a vicious spiral, and depression and anxiety as well. So when we're using pharmacologic intervention for this is sort of the tier 1 go-to. You can use medications like gabapentin and pregabalin, which were initially developed as anticonvulsants, antidepressants, including tricyclics or SNRIs, and topical agents, including a lidocaine patch or capsaicin patch, which also can sometimes cause skin irritation. So there's certain things to bear in mind. There are also, depending on if you use like compounding pharmacies, Apthorpe Pharmacy on the Upper West Side is a great compounding pharmacy. Sometimes you can find other topicals that aren't routinely prescribed. Patients will usually have to pay more for this, but if they need more options, there's literature to support efficacy of gabapentin or phenytoin preparations topically, or ketamine, which I don't prescribe ketamine, but a lot of people do in the pain world as well, or oral ketamine for that matter. I tend to use for patients, I look at their whole picture. So if the neuropathy pain is worse at night, I like to look at something like gabapentin or pregabalin, because gabapentin, by nature of its central nervous system effects, has a natural effect for a lot of people of calming them down and helping them sleep. So I like to turn to that and use that for them. I personally don't love amitriptyline because of the tricyclic interactions and side effects and so forth, which can be bothersome from patients and cause other complications. So everyone is a little bit different. Duloxetine, some patients have some initial nausea or jitteriness, but you can slowly titrate it. And for most patients, it's not sedating, so that can be a nice daytime option for patients whose symptoms bother them all day long. I look at it in terms of obviously other medical problems that they have. If there's an element of depression, what other medications are they on? Look, so I look at these things as sort of like, can I solve more than one problem with this neuropathic pain medication? Obviously not cause more problems. And for each patient, I talk to them and say, we have a lot of options. And my goal is this has to help you, and this has to not make anything else worse. So it's a really big balancing act, partnering very closely with patients. Tiers 2 and 3 include other medications. And then really, as you'll notice, as we get down in the tiers, we start mentioning the opioids in general. And what I would say is that, in terms of how do we think about as neurologists the use of opioid medications for chronic neuropathic pain? And in essence, the answer is that we tend to not use them. So the idea being that there's insufficient evidence that opioids are effective for the treatment of chronic pain, particularly neuropathic pain. They lump all the neurological conditions here, so obviously we're not talking about migraine, but that I think that in general we do reserve opioid treatment for the most severe patients where they can barely function, they cannot sleep at night, and even then, if I'm using it in those patients, it's not a long-term issue. It's really bridging us to figuring out what else is out there to really, help them get through this. So this is something that we don't turn to. Certainly not as tier 1 or tier 2, and if we're using it, it's usually like very short term because there's something that's spiraling out of control for some reason, and we're communicating with the patient, we're getting you through this to whatever else it is that we're going to be helping them with over the longer term. And then, of course, there's medicinal cannabis for neuropathic pain. There's a lot of studies out there that have shown benefits for a variety of neurological conditions, including neuropathic pain from peripheral neuropathy. But then we have the dark side, which is the fact that we don't know, and you guys probably know this, but we really don't know so much about what patients are taking. I mean, when you prescribe gabapentin, you know the dose they're taking, you know what it is, you know what's not in it. And yet when we look at these studies about medicinal cannabis, and then we give patients, I actually have the ability to certify patients in New York State for this, and occasionally I help patients with this. But the idea being that the dispensaries, there's all these different compounds. A lot of this research is done in Europe because in the United States, the scheduling of cannabis is such that it is very restrictive for people to do broad kind of trials or to get funding from the government to fund this research, which the AEN is in support of changing the scheduling of cannabis so that we can actually do real clinical trials and get federal funding for this important research. So oftentimes, even if your patients are taking this, we don't know is what they're taking the same as what the research showed is effective, depending on where they're getting this, or if they're just going to like a recreational, kind of environment. You don't know what they're getting. You don't know what else is in it. And so obviously this is a problem, and hopefully, I think, hopefully we'll be on a path to improving this situation across the board for all treatments, over time with more standardized research and standardized applications and understanding of what exactly we can give our patients that's helpful. But the fact is that some patients find it helpful. I've had some patients tell me it helps them sleep. I've had some patients tell me that it makes them feel depressed. So it's a very careful balance. But I use it on an individualized basis in a minority of cases. Now, non-pharmacological management of neuropathy symptoms, I think all of us have been witness to the trend of really looking more closely at what can we help patients with in terms of quality of life and pain in particular, outside of medications, particularly in an area of concern about the opioid epidemic. And there's a lot that we can do. So nutrition and exercise, this is actually me with the residents from Mount Sinai Hospital in Central Park. We do some wellness stuff there, which is a lot of fun when the weather's better. But in essence, looking at nutrition and exercise for diabetic neuropathy, maintaining obviously good glycemic control for patients who have diabetes, and really talking to patients, making sure that they understand the choices that, to make in terms of diet can be helpful. If they have a good nutritionist or endocrinologist, they're probably already doing this. Then there have been trials looking at other types of activity like yoga. Nobody, I don't know who, could do daily yoga for 40 days for 30 to 40 minutes a day, but they showed some improvement. And it's, again, some of these studies are like one-offs, like improvement in nerve conduction velocities, and it's really like mind-bending, but I'm just telling you what's out there. I don't understand how the nerve conduction velocities improved, but there is this study out there, and I don't know who could do this for 40 days, but it's kind of incredible. So I think, just to make you aware, Tai Chi, actually, I think in my mind, just intuitively, for patients who are drawn to Tai Chi, this actually, number one, is a safe practice. Yoga can sometimes be not that great or safe, especially for patients with spine problems, but Tai Chi is really safe for patients, including patients who have balance problems. They're not going to be standing on their head or doing anything weird potentially. And it really can help in terms of proprioceptive sense and balance, and in terms of like calming effects as well. Mind-body therapy, in terms of biofeedback, can have a lot of great effects for pain and a lot of other conditions as well. But again, it's some of the limitations can be great for some patients. Some of the limitations for other patients is, can they find either someone to support them with this or an environment where they can really learn how to do it and then do it on their own. It can be a challenge. But one thing that I think is important to know, why it's important to know about a lot of these types of, whether it's exercise or other things I'm about to mention, is that our patients are using them. And this is just an example of a survey where they looked at patients with peripheral neuropathy, and almost half of them had used some form of complementary alternative medicine, most frequently for pain control. And a third of them thought their neuropathy improved. And so, what's important to know is, I think it's important to know kind of some of the literature behind this, whether or not we believe that it's correct or that it's valid, because patients are using it. You want to be able to speak to them about it. Occasionally, patients are doing things that you're not sure are safe. And so it's nice to know, like, when you want to caution a patient, this you might think is helping you, but I think this is dangerous or could be making your condition worse, and to be able to engage with patients in that conversation. So depending on your thought about some of these interventions, maybe it is a placebo effect. This is, for any of you who are interested, this is actually a book where this guy says, what if we could counsel patients to engage the placebo effect, but without a placebo? And it's kind of this wild ride of all these different medical stories of people having surgery just without anesthesia and all these sort of things. But if you're interested in that, but regardless, I think we have to be aware. I don't say to patients, oh, it's probably just the placebo effect, but I think kind of engaging them, because ultimately if we can help them in whatever way that's safe, feel better, that ultimately has a benefit for patients as well. Acupuncture is one of the modalities that has the most kind of scientific literature behind it in terms of pain control efficacy. Of course, in terms of rectifying the Eastern and Western medical fields, it's hard to kind of explain. But there are some studies which show that it stimulates endorphins and helps alleviate pain. It is usually a temporary benefit. It's not a permanent benefit for most patients. I mentioned here the Pacific College of Health and Science, which has a branch in New York. It was previously called the Pacific College of Oriental Medicine, but was recently renamed. And actually, when I was in medical school, we did like a elective there, which was really interesting, where we had acupuncture and talked to some of these practitioners about some of these modalities. So I think it's interesting, but if you have a patient who's interested in this, it's important that they go somewhere reputable. And so I offer this, and also this institution offers discounted acupuncture, especially because they're working in a school environment. So I think it's a nice resource for certain patients, especially patients where cost is a really big factor. So if patients are interested, I'll recommend that they try this. Then there's stuff like this. bioelectromagnetic. So there's something called mag steps, which are insoles for your shoes, which are magnetic. And they say these magnetic fields can penetrate the skin and appear to target pain receptors. And so then they did this randomized controlled study where patients who wore these for 4 months had a significant reduction in their symptoms. So I have no idea, what to make of this. I guess we could talk to the people who work in the MRI suite and say, we can put patients, take them in and out of the MRI suite. I don't know. But these things are out there. So I think it's worth knowing about them. Then there's all these botanicals. So a lot of these botanicals tend to have, in terms of basic science studies, antioxidant properties, and anything with an antioxidant, then everyone says, well, therefore it must help with all these other conditions. What I usually counsel patients on, so first of all, the vitamins, there's really no evidence that unless you're deficient in the vitamin, that having mega doses of vitamins makes things any better. But there are people who market them that way. So I think with respect to this, I talk to patients about cost. Are they spending all their hard-earned money on these things that may not be helping them? Some agents, can cause toxicity. So B6 in excess can actually cause neuropathy, ironically. So, there's a few caveats that I'll make sure that patients are aware of, and I'll say, will this help you? It might help you. We don't have any good science that it will. Please don't spend, if you don't have a lot of money, don't spend your money on these things. If you feel like they're helping you and it's not breaking the bank, then fine, if it's not causing any problems. And again, this is just kind of reiterating some of the points that I was making before. So the importance of communication, this is one slide. I think, again, as we've said, it's important, to not say to patients, I can do nothing for you. There's a lot of help that we can offer patients, including symptomatic management and counseling them over time. And so talking to them about, that you're partnering with them on a long-term basis. And actually there are studies that in terms of optimizing physician-patient communication improves adherence, improves patient experience for those of you in the Press Ganey world. And not only that physicians tend to find more sense of meaning in their work if they feel like they have good communication relationships with their patients as well. So sometimes patients come to me for quote unquote a second opinion, but all we end up doing is talking and listening and talking about exercise programs and maybe adjusting the gabapentin dose. But for them, that makes a really big impact in their life. Resources for providers. So this is actually a textbook. They have multiple editions, and it is a huge compilation of all kinds of different integrative medicine approaches. So if you want to have something where you can look up things, not just for neurological issues, but for anything and what's out there, whether it's science or pseudoscience, this is actually a nice, easy one-stop shop resource. This website, the Washington University Neuromuscular website, is a phenomenal website, which I use all the time. It's almost like an online textbook for neuromuscular diseases, but they also wrap in other stuff like spinal cord. You can actually, there's a search box, so you can use it like Google and it will search content for you. You can look by antibodies. There's a search box. You can look by antibodies. You can look by sort of the type of disease state you're looking at. You can see they update it monthly when new papers come out. So if you want to get an update on something or see what's new, you can click there. They must devote an enormous amount of effort into maintaining this, but it is and has remained for a long, long time a very reliable and excellent resource. They even have one-page summaries of antibodies, all these really great things. So I highly, highly recommend this. If you're looking for resources for patients, these are some good recommendations for physical activity. This exercise and physical activity, you can find this online as a PDF. It's actually great, made by the National Institute on Aging, and it gives patients, it's age appropriate for older patients who may have balance or spine problems. Exercises using things like cans of soup and a chair in their house and a towel. So actually that's very helpful. This book on the left, this guy is actually a sports medicine guy at HSS, but he does all this New York City exercise stuff for triathletes, and then he publishes a ton of books. But one of the things I like about his books is that he organizes them by sort of problem, whether it's balance problem or you sit at a desk all day long and you have back pain, and he gives you one page of here's some stretches and basic exercises you can do on your own. So for patients who are maybe a little bit more physically active to begin with, this can be actually a great resource for them, and they can pay $10 or $12 as opposed to $40 copay for PT. And for some patients who are more motivated, this can be actually a nice kind of route to go. Other resources for patients. This is a book on peripheral neuropathy. It goes from nuts, soup to nuts on the physiology of nerves a little bit, but kind of at a more lay person's perspective, all the way through different symptomatic management options and so forth. But it's a nice, thin book for patients who are really interested in learning more and like reading a book about their condition. The Foundation for Peripheral Neuropathy, I actually work with them as a patient education advisor, and they really have great websites and newsletters, and we do a lot of material on the content that I've mentioned here in terms of helping patients with their condition chronically. So that can be a nice, and they do patient education webinars and lots of different things. So that's all. Thank you guys so much for your time, and I welcome any questions, and it's an honor again to be here.
I really want to thank you for what I think was a moment in courage to tackle this immense subject in place of an hour, and you definitely did it. Just one observation. Now that we have a treatment to stabilize amyloid doses, I just make a plea that internists who see probably one of the most common mononeuropathies, which is carpal tunnel syndrome, that if in fact they have a patient with either autonomic symptoms recovered or evidence of a cardiomyopathy with a normal ejection fraction, that would suggest amyloid, that when you refer this patient to your local orthopedist, please insist that they do a pathological examination on the flexor retinaculum when they do the surgery. That would allow you to make an early diagnosis of amyloid, which obviously can affect the peripheral nerves as well.
Thank you, Carl.
Thank you for a great talk, but I wanted to bring out something that you don't think of as peripheral neuropathy, and that is about 14% of diabetics not presenting with symptoms of respiratory symptoms, when tested with a phrenic nerve, will show a phrenic neuropathy. And I know that's not a common nerve to be assessed, but they're short of breath. Many of the diabetic patients are obese, so you describe with their obesity, but it's almost never seen without some peripheral nerve symptoms. So just to think of it when they have shortness of breath along with peripheral nerve symptoms. That's one. The other I wanted to ask you was how much obesity alters the sensitivity of the EMG and nerve conduction tube.
Thank you so much. So it alters it a lot. And I think that if you have, that's where, one of the things I didn't get into is that the usefulness of EMG nerve conduction studies is very user dependent. It's a technique that it's not an MRI where the patient goes into the machine and it's the same protocol. It's a technique where the practitioner is putting the electrodes on the patient. The practitioner is observing what technical interferences might be at play, and then making the report. So if a patient has anything that comes between the surface of their skin and the nerve, that influences the amplitude of the response, and it influences potentially your ability to detect a response. So when we have patients, for example, in the ICU, sometimes where we're trying to do a study and they have like anasarca and everything's totally dematous, sometimes it's very hard to get any nerve conduction responses, and we know that if we get them in the reduced amplitude, we're not sure if that's meaningful or if it's just because of a loss of amplitude at the skin level because it's just dispersing in the tissue. Similarly, if a patient is really obese, one, it's a more uncomfortable test because we have to use higher levels of stimulation to get through the tissue to stimulate the nerve. And we know in some cases that there may be a technical impediment. So that's where I think if you are a thoughtful electromyographer, you look at the patient, you look at the situation to begin with, you put the whole thing together with their clinical history and symptoms. And in some cases, you might have abnormalities on their test, which you say these we suspect may be technical in origin. Or for example, when we're stimulating at sites more proximally, like behind the knee, where there may be a lot of tissue and we suddenly see an amplitude drop, as opposed to saying, depending on the clinical context, oh, we think this patient has conduction block. We'll say, oh, this we suspect that this site was due to technical limitations, and we may, include something about patient habitus and so forth. But it's a humongous feature, And, you can in theory do things like stick electrode wires underneath their skin to do near nerve recordings. One that's much more comfortable for patients, and sometimes it's really not practical depending on the clinical situation, and those electrodes are not routinely available. But it's a massive feature, and I think you break through this by knowing that you're working with a good electromyographer, but it is not uncommon that we see patients who also have a variety of different false diagnoses, that when we repeat the testing with a more critical kind of assessment, that we say, actually, you don't have neuropathy, or some of the sadder cases or happier cases, you don't have ALS, or you do have ALS, or whatever. So I think there's a lot of different features that can't be underestimated.
The thing that bothers me in long-term care of my primary practice is always my failures. So I want to emphasize a couple of things that I learned from failing. One is that metformin, when it's one of the most common medicines I prescribe, it causes B12 deficiency. And often it doesn't cause B12 deficiency, it causes B12 insufficiency. So it's down there in the low range and you treat it, and people get better with their gain. Secondly, is that when you recognize peripheral neuropathy, especially spinal stenosis, the problem is the consequences of this are often falls and hip fracture. And that, I can't tell you how many times I've seen that. Done a physical exam on people, I said, oh yeah, you have some degree of peripheral neuropathy. I write it down in the chart, but it turns out the next week or 2 weeks or 3 months or a year later, person falls, breaks their hip, and never gets out of the nursing home. Very serious. Another one is that you didn't mention, but it's an interesting thing that I've seen is people with chronic cough. Now, when you eliminate the fact that they're not on an ACE inhibitor, they don't have reflux, they don't have COPD, they have a normal chest X-ray and PFT, sometimes it's vagal hypersensitivity. And people come to you over and over again. I got this cough. I can't get rid of the cough. It started when I had a cold. It persists now for 6 months. What am I going to do? Gabapentin sometimes works. The last thing is, are Raynaud's phenomenon and maybe even princemental angina neuropathies?
Thank you so much for those points. So the going backwards and reversing, so the Raynaud's phenomenon, I've definitely had patients who've come to me with isolated Raynaud's phenomenon, and we've done workups and including skin biopsies, and it doesn't always map out to small fiber neuropathy. When you look at it, or things like even erythromelalgia and all these other vasodynamic skin changes, there's really no hard and fast literature that says that this is the same thing. Although for some patients, when you dig deeper, they do have small fiber neuropathy, but it is not itself a neuropathy. So it is challenging, and I do see patients sometimes who come to me for this or referred because there's a concern, could they have a neuropathy? And I guess the overlap diagram is that sometimes, but not always. The gabapentin point with the cough is absolutely really interesting. And actually recently we saw a patient here on the inpatient service who had a cough, chronic cough, but she had metastatic cancer with some cranial nerve involvement, which was very sad. But actually gabapentin really helped her, thankfully. And your point about falls is very well taken, and it is one of the big kind of quality assessment indicators for, I think, neurology and rehabilitation services. Dr. Malcolm Reed gives us like amazing Q-pick presentation each year on falls, and falls is, something that is, falls are just really kind of a life-changing or life-ending for some patients event. And so screening for gait instability, screening for fall risk, asking patients if they haven't fallen, asking them, do they trip or do they have near falls? These are things that we look for all the time. In terms of an additional step on the neurological exam, if you're thinking about just sensory loss in their feet and how unstable they might be, having the patients do what we call like the Romberg maneuver, having them stand with their feet together and their arms up and their eyes closed and seeing what happens. And if they start suddenly flailing, that's a sign that they may have a big fall risk just from the sensory neuropathy alone, even if everything else is working perfectly. And these are patients that I say, like, be very mindful if you cannot see well and use other senses to help improve your stability. I say, like, maybe let's get a cane or a walker for certain environments. I say, I don't want you getting up to go to the bathroom in the dark, turn on the lights. I don't want you walking in the dark on slippery streets. We have to look at your footwear. We have to look at other safety interventions at minimum. Or I always say to patients, if you are in a situation and you acutely feel unsteady like that, widen your stance. And I kind of, even though we don't endorse football in neurology, I say, think about a football player and how they make themselves more stable by widening their stance. And that usually for people, they kind of have an aha moment, and it helps them kind of think, if assuming that they have good strength, that that's something they can do quickly in a second, which will help give them a wider base and more stability and perhaps prevent some falls or near falls.
Just one more question. Go ahead, Bob.
The last surviving member, but I've had some concerns about the overdiagnosis and polypharmacy, and most of the patients that I see with diabetes come in taking gabapentin, and they've been taking it forever. And I know the natural history of diabetic neuropathy is that the painful neuropathy disappears as the neuropathy gets more severe. On the other hand, there are other benefits of gabapentin, including the sleep and the placebo effect. Should I bother to try and wean these people off, or should I just leave them off?
No, absolutely. Wean them off. So I think I always like talking to patients and saying, I mean, if they truly have some intractable insomnia and they can't sleep and this is really what's helping them hold their nights together, then that's one thing. But otherwise, I always say to patients, and I use the contrast of like antibiotics, and I'll say, when you take an antibiotic, this is something that somebody instructs you to take for a reason, where they say, you have to take this even if it causes bad side effects. It's important because it's treating your condition, and without it, we have problems. And I always emphasize, for any medication we're using for pain, this is really in your hands. This has to be helping you. And if it's not helping you, then we're not going to use it. And sometimes they don't, they need a different medication. But I also point out to them, this is for pain. And this is not treating all symptoms of neuropathy. It will not help with balance. It will not help with numbness. It will not help with weakness. And so if they have pain and this has to make their pain better, then fine. But if they don't have pain and they're not sure if they have pain, then we say, let's slowly go down and see if anything changes. Or if they started taking it years ago and they say, I can't remember why I'm taking this, or if it's helping me, I say, okay, let's go down on it and see if anything gets worse and take you off of it. And if nothing gets worse, then absolutely, because it can have sedating effects, and there are other problems with gabapentin.
Thank you for the excellent lecture. I have two questions. So in the primary care practice, if I have a patient with a polyneuropathy and I do the initial work on this, should I go ahead and order the vitamin levels, like the B6 and thiamine and zinc level, basically? What is the chance that somebody living here eating a normal diet actually has low levels of these vitamins? And what is the diagnostic yield of the blood test that we order? And should we just start them directly on a multivitamin instead of doing the lab test? And the other question is for obese patients. Instead of doing the EMG, would you just go to the skin biopsy, because it will be higher yield for them? Thank you.
Sure. So for the vitamin levels, I think, again, for most patients, for some patients, if they drink more than they will tell you, occasionally you'll find that they have some thiamine deficiency or borderline vitamin deficiencies, but they didn't tell you how much they're drinking. So in terms of patients that we might just see here in the city, we wouldn't expect them, if they have a normal, healthy diet, to have vitamin deficiencies. The other group that I would say, but I think all of us would think of this, that we've seen it, is patients who've had some bariatric procedures. Even when they say, well, this type of procedure shouldn't cause these deficiencies, I think for some of these patients, and maybe there's more going on than we understand, they end up having a deficiency in a neuropathy. So I think that, as opposed to telling patients take multivitamins, always, if we don't know, I usually don't do that, because sometimes, depending on the patient, they end up spending exotic amounts of money on exotic multivitamins, or they don't know why. And also sometimes multivitamins can have toxic effects depending on what they end up taking. So if it's a matter of putting to rest, checking a thiamine level or a B6 level once, I'll do it. And with respect to the B6 question, sometimes patients are taking bizarre high doses of vitamins because they think it's good for them and it's causing problems. So I usually do the vitamin levels once if a patient makes it to me and we don't know what's going on and they've never had them checked. I usually don't say prescribe multivitamins, because if they have a true deficiency, they need higher doses than what may be found in a routine multivitamin as well. And with respect to the obesity, I do EMGs on those patients, and not, I mean, I stare at so many feet and hands, but if you think about, adipose tissue distributions, in some patients, they don't have, that's not an issue for in the realm of their foot or their hand, where we're testing a lot of the nerve conduction studies at those sites. Or in some patients, if we kind of move the tissue a little bit manually as we're testing and use a slightly higher impulse, we're still able to get a good response. And even if the amplitude is a little reduced, but the velocity is normal and you put the whole thing together, it can help you make the diagnosis or refute the diagnosis. And the skin biopsy is only helpful for isolated small fiber sensory neuropathy. So depending on the patient, it may or may not yield the full diagnosis of their condition. It's not necessarily that the small fiber neuropathy is the same thing as the larger fiber neuropathy, but like at a different moment in time. So to use it as a surrogate, one, it may not be clinically accurate, and two, insurance might not cover the pathology, because one of the things you have to check off the box is if they've had an EMG that was normal.
Thank you very much, Shanna.
Thank you.